Anna should hopefully be joining here shortly. And we have Priyanka and Gurleen who will be helping with scribing and teaching points. Priyanka and Gurleen, why don't you introduce yourselves? Before you do though, a quick plug as always, we will need 2 discussants, at least one of which ideally identifies as female or non-binary. And we also need someone to volunteer to be our case presenter for the day. So 3 volunteers in total, 2 discussants and 1 case presenter. And with that, let me turn it over to Gurleen to introduce herself.
Hi, everyone. I'm Gurleen. I'm a 4th-year medical student at Albany Medical College in New York, and I'll be scribing today. Great to see all of you guys.
Hi, everyone. I'm Priyanka. I'm a 4th-year medical student at UCSF, and I will be doing teaching points today, and I'm really excited to be here and learn from you all.
Gurleen and Priyanka, we're thrilled to have you. So as I had mentioned earlier, we'd love to get, it looks like we have a discussant. Sandra has volunteered. So we still need 1 other discussant and then a case presenter. Sandra, why don't you go ahead and introduce yourself?
Hi everyone, this is Sandra. So I was writing here that I have discussed in previous sessions, and I really don't mind if someone else wants to discuss, and I encourage that. However, like if there's anyone else, I'm willing to do it. I am Sandra. I was born and raised in Cape Verde, West Africa. I study medicine in Bolivia, and now I am living in New York, currently doing clinical research in neurology department at Columbia University. And I speak 4 languages, Cape Verdean Creole, Portuguese, Spanish, and English. And I myself represent 3 minorities in 1 person. I identify as a Black woman and also immigrants, I would say. Yes, I think that's enough. I will stop there. And it's a pleasure to be here as always.
Sandra, so we've discussed before, and it was such a privilege for me to get to share aliquots with you in the past. So I'm very happy that you've rejoined us in the lukewarm seat. I see that Anna has been able to join us as well, my partner in crime for the evening, and one of my co-discussants. So let me turn it over to Anna to let her introduce herself. And if she has any reflections, go ahead and share those. In the meantime, I believe we still need 1 other discussant to join myself and Anna along with Sandra, and then 1 case presenter.
Awesome. I'm so sorry for being late, everyone. I had a bit of a bike tire problem on my bike ride home. So I'm both sweaty, but hopefully I have adequately perfused my brain. I'm super excited to discuss a case with Sandra. And then, yes, we would love to echo Priyanka's comments. We would love someone else to join us and give us a great case to talk about. For those who I haven't met before, my name's Anna. I am a 2nd-year resident in internal medicine. I'm based in San Francisco. And I'm one of the CP solvers. I'm also part of the WDX community. Yeah, I'm just really excited to discuss a case. I have never discussed a case during a week. So this is like a first time for me. So if you're a first time discussant and you also want to be like a first timer, you and I can partner up and we can be a first time team. Normally I do like the student VMRs on the weekend. They're not videotaped. They're not like recorded. They don't go up on a website. So I feel like I'm in my safe bubble. And so this feels like a more vulnerable platform, but I'm really excited and I know we're going to have a good time. I can share a reflection from yesterday's case. We had an awesome case. Thank you so much to Drew for presenting yesterday. It was a case of a middle-aged man who had been out of medical care and was experiencing homelessness, who presented with several months of heart failure symptoms. And then, not to anchor early, he really presented with lower extremity edema and shortness of breath. And it was just like a great bread and butter medicine case of kind of thinking about those concerns that we see so frequently, and really like using great physical exam skills to localize the lesion. And we were thinking about just a generally volume overloaded state, kind of what systems, where could we see pathology that would explain that. And so, you know, really when you see lower extremity edema, you're from a diagnostic perspective, just look up, take a look at the patient's respiratory status, take a look at their abdomen, take a look to see if they have signs of cirrhosis. We used our physical exam skills to localize the lesion to the heart. The patient clinically presented with heart failure, was found to have newly reduced ejection fraction that was non-ischemic in nature. And we didn't dive too much into kind of the workup of non-ischemic heart disease. What we did talk a lot about yesterday was our practice of anti-racism in medicine, and about how, you know, there were certain factors that really influenced the way that this patient was able to interact with the medical community. This patient was an African-American individual whose barriers to presenting to care, the way, you know, their kind of openness to communicating with medical providers, the way that they're able to self-advocate for themselves in a medical encounter is, you know, really influenced by the way that the medical community has treated certain groups for really centuries. And so, you know, we talked about this and how important it is that, you know, when you're, you know, seeing an individual who's presenting to you clinically, it's really important to like, you know, sit down with the individual in front of you and kind of try to look past the biases that you might carry into a clinical interaction, and really dig deeper to understand your patient's stories, and you know, why it might be difficult for them to participate in that particular clinical interaction. There was a great paper that one of the medical students, Lauren, shared. It was a paper in the Lancet, and I'm actually just going to pull it up and drop it in the chat for you all, because I thought it was really, really great. And those are my reflections from yesterday's case. Sorry if that was a little bit rambly. Anyway, I will turn it back over. Do we have any other discussants or anybody who is interested in presenting a case today?
It looks like Mario has volunteered to join us as a discussant.
Yeah.
Given that we're getting 10 past the hour, Mario, we'd love to have you discuss with us, even though you've discussed before. Still looking for a case presenter, but in the meantime, Mario, please go ahead and introduce yourself.
Yes, hi everyone, my name is Mario. I'm a 6th year med student from Lima, Peru. I have discussed a couple of times. I think I've discussed with Sandra before, so that's pretty cool. So really excited to discuss another case.
Yes, same.
We're very excited to have you. While we're waiting for a case discussant, or sorry, a case presenter to jump in, Anna, Sandra and I have discussed before, so I'm going to ask to switch it up, and I'm going to pair up with Mario this time around. Do you have a preference in terms of whether you and Sandra want to tackle aliquot 1 or 2?
Sandra, I defer to you. What do you prefer?
1.
Yes, let's get it.
Okay.
That was the link that I posted, the paper from the Lancet on race conscious medicine. The other thing I wanted to throw out, if somebody is interested in kind of presenting a case but doesn't have a case themselves, we have like a backup list of cases that folks can use. So also, if you're interested in that, I know it's sometimes hard to remember to write down. Although what I have, while maybe people are thinking about volunteering, that one practice that I've actually started doing is that as I'm seeing interesting cases, as I'm, either admitting people or on a consulting service, and I am interested, I write down a couple things about that patient, and that I actually keep a secure spreadsheet where I write down patients, either their first, last name, their medical record number, so that I can reference it. It's not only a really good way to kind of check in with your clinical reasoning skills. You were thinking this at a patient had a clinical syndrome at a certain point in time. You're collecting diagnostic information, presumably certain treatments were done. And then in the end, you'll get hopefully what the final diagnosis was. And it's a great way to look back in retrospect and figure out if the way you were thinking about that was correct. And that it also is a great repository for cases to share with folks. And it looks like Fernand might have a case. As always, can always count on you.
Fernand, why don't you go ahead and introduce yourself for the few folks in the audience who may not know you. You're one of our VMR stalwarts. So please go ahead and introduce yourself, and then we'll try to jump into the case shortly thereafter.
Okay, hi everybody. This is Fernand. I'm a Hemoc fellow, first year from Albert Einstein in New York. I have an interesting case, but I may stutter a little bit because I will kind of build it along the way, basically.
That sounds great. We're excited to hear it. With that, Gurleen and Priyanka. Oh, perfect. We've got our screen up. And as soon as Gurleen and Priyanka give us the thumbs up, Fernand, why don't you go ahead and start giving us aliquot number 1, which Anna and Sandra are going to tackle.
Okay, this is a 70-ish-year-old female who comes to the emergency department because she's been having worsening fatigue, and she had the COVID vaccine a week before that. During that week where she felt tired, she was diagnosed with UTI. I'm not sure about the details, and was prescribed nitrofurantoin. In the emergency department, they did some lab work and they found a hemoglobin of 2.5. And so they gave her some transfusions and were trying to figure what's going on. I'll stop there.
My goodness, that is quite the shocking number. Off to a good start though. All right, Sandra, we are seeing this woman, you and I together. We're heading down to the ED. We've been told these numbers by the ED provider. Tell me some of the first questions that you're thinking, some of the first things, some of the first pieces of information you're hoping to collect when we go see this woman.
Okay. So I'll make sure that the patient is stable, because that's the first thing to take into account. To stabilize, if it's not, to stabilize the patient first, to do the that's the first thing to see in a patient, especially in ER. Secondly, let's assume that even though with this hemoglobin, I doubt that she's probably not stable, and for her age, 70 years old as well. Sorry. It's hard to say if she will be stable. In case that she's not able to provide information, it would be important to see if there's any informant, reliable informant. Also, we already have a medical history, and we know here in US mostly use EMR, so it could be easier for us to access information. But obviously that's the part that you do after first taking care of the patient and then go for more information. But with this hemoglobin and fatigue, I would definitely look for bleeding, for any bleeding, so losing blood. It can have many ways that someone can be losing blood, having a bleeding. So it can be GI tract, it can be the urinary tract, and also with an antecedent of a UTI and taking nitrofurantoin could make us think that could be affected the nephrons, specifically the glomerulus, and having a bleeding that she's having a bleeding on the urinary tract. Also, there are other ways that you can lose I said GI, but also like internally, if there's any bleeding, you could see if it's a upper part or lower part. So those things are mostly related to really low hemoglobin. However, it can sometimes it's not evident, the bleeding. So if it's not evident, you have to investigate. But definitely with that hemoglobin, there's a problem with her blood and specifically with the RBCs.
That was absolutely exceptional, Sandra. I don't think you left a single rock unturned in thinking about like your first pass approach to anemia. And I agree with you, like the history is everything here. So we're seeing this woman, it'll be really interesting using our EMR to like see if she has any prior normal ranges, but like to have a hemoglobin of 2.5 and like not have like an insane clinical history for some type of bleeding. I agree with you in that I'm thinking about like causes of anemia that do not involve blood loss. And I'm seeing Fernand smile, and I think this is going to be some type of hemonc case, knowing his specialty. And that makes me nervous because I'm not good at hematology, but I'm going to learn a lot, which is great. But yeah, it's a very pretty severe lab presentation. And so it'll be interesting that when we examine the patient, like, are there signs of hypovolemia once we examine the patient that would match, you know, a history for blood loss. So I totally agree with you. When I'm thinking about anemia, I'm thinking about, are there red blood cells being lost somewhere? Are they not being produced, or are they being destroyed? That's like my kind of like gross categorization of what could be going on. And so we've already talked a little bit about like, could this be blood loss from somewhere? And I'm thinking about those same systems as you, GI, GU being probably like the most common sites of bleeding for people. And thinking about whether or not this is a production process, like could there be, is there something like lingering in the background? Is this fatigue? Has this been something that's been going on for like quite some time? And there could be, the patient could be systemically unwell, and she could have, you know, suppression of her red blood cell production. Could she have like a marrow process? And then lastly, are the red blood cells being destroyed somewhere? So is she having some type of hemolytic process? Does this have anything to do with nitrofurantoin, which is a cause of hemolysis? Does this have anything to do with the COVID vaccine? I feel like we're, you know, because it's, we could think of it as like a new medication. We're still figuring out side effects from this. And to be honest, I don't know a lot of the side effects aside from the general malaise that people talk about. So I would be searching right now if there are case reports of hemolysis associated with the COVID vaccine. And so those are the three kind of buckets that I'm thinking of. I think, getting a little bit more clinical history, I'm interested to hear what her past medical history, if there's any prior abnormal lab values. And then I really want to get like a good physical exam on her, look for other signs. Is the patient perhaps coagulopathic from some type of catastrophic hemolytic process, or look for things like, bruising, and of course for any evidence of blood loss from the GI or the GU tract as well. Those are my first thoughts, but I'm really excited to see where this case goes. Are there any other things that came into your mind after our discussion, Sandra?
So it's not clear for me that if the UTI was resolved, like if because she was she started 1 week ago taking the medication, and let's say if it's not resolved, it could mean that an infection and low immunity and taking a vaccine with a low immunity could have more side effects as well. But let's see.
Yeah, let's see. The only last thing I wanted to bring up is something that an attending just taught me when I was senioring this past month, was that when we're evaluating anemia in the inpatient, of course, this is such a severe anemia that we're probably going to do more, but like a good first pass workup, you can actually rule out a lot with just looking at a patient's retic count and calculating their reticulocyte index, looking at a smear and getting a ferritin. And we can cover a lot of ground just with those. And it can kind of, and of course, using the patient's MCV. And that can give us a pretty good sense of kind of where to guide our diagnostic workup. But let's see some more info.
All right, good initial discussion. Just 2 comments. I think UTIs are sometimes overdiagnosed or misdiagnosed. So what if this was not a UTI? I think we have to keep our mind open. You'll probably understand later. And second thing, you talked about general malaise with COVID vaccine. I had full-blown SIRS at night with the 2nd dose. So there are some pretty severe side effects. So going back to our patient, she basically was asked the typical questions. Have you been bleeding recently? Any overt hematuria or melena or hematochezia? She denied any of this. She said that she went to see her endocrinologist, I believe, in December, and there was some mention of anemia. It was not the first time she knew she had anemia. If you look back at her records, she had a hemoglobin around 8.5 gram per deciliter at that time. It was hovering around 8 to 9 around that period of time. Not much was done for the anemia at that point, but now we have a sharp drop in it. Other than this, when we asked her if she had any systemic symptoms, she mentioned the weight loss of 10 to 12 pounds over the last few months. She has had fever the last few days before she came. At least she mentioned the 100.8 once, and she's been feeling tired overall. She mentioned also that her urine was dark 2 to 3 days before she sought medical attention. So this was something that stayed in her mind. As far as past history, she has a medical history of sarcoidosis. Mainly, it's a pulmonary sarcoidosis that's not actively treated. She does have rheumatoid arthritis. She does have essential hypertension, gout. She had thyroid cancer and was treated definitively with radioiodine. And in terms of surgery, I don't believe she had any pertinent surgical history. The medications she was on included weekly methotrexate for her rheumatoid arthritis. She was on allopurinol for her gout. She had been on folic acid with her methotrexate. She takes ibuprofen from time to time. She takes levothyroxine for hypothyroidism. She takes montelukast for her. I'm not sure why she takes it. If her sarcoidosis has some asthma-like syndrome, and she's on telmisartan for her hypertension. No history of anemia in the family. Patient works as a registered nurse. She does not smoke, does not drink, does not use drugs. And she has allergy to some antibiotics, but the allergy is not specified. It's mainly a cephalosporin allergy, but it doesn't seem like it's anaphylaxis. So I'll stop there.
All right, Mario, we've got a ton of information to parse through. What are your thoughts as we have a little more of the background of this patient?
Okay, so I'll try to go over the past medical. No, okay, we got I forgot the rest of the HPI. I think we already know the hemoglobin. I think a very helpful step would be to know if there are other cytopenias. I'm sure we'll learn that later, because I think that would make me think if this a production a bone marrow problem, maybe a peripheral destruction problem. The weight loss and the weight loss in this context makes me think: is there a inflammatory process going on? We had to localize it where. And the dark urine, I usually associate that with: is there blood in the urine? Is there hemoglobin in the urine, or is there myoglobin in the urine? I would probably think this is more of a we'll find in that it's a dipstick hemoglobin there, but we have to work that up. And in terms of the past medical history, sarcoidosis and this level of anemia, I'm not sure if maybe sarcoid being a granulomatous disease can infiltrate the bone marrow. Rheumatoid arthritis, it has many extra articular manifestations. I'm not sure if it can present with a hemolytic process, or maybe also a bone marrow aplasia type process. In terms of the gout, the most common type of gout is from less uric acid excretion, but there's also more uric acid production in terms of proliferative neoplasms in like polycythemia vera, and those, I think I butchered the name, but I mean like proliferative neoplasms, myeloproliferative neoplasms. There we go. And the thyroid cancer, I'm sure it's already was hopefully cured, but maybe could metastasize to the bone marrow. And that's all I've got.
Mario, that was beautifully laid out. I love how you kind of went through our patient's past history point by point and kind of talked about how it influences our very broad differential. So I think, I'm going to do something a little similar to what you did and just layer my thoughts on top of it. So I agree with everything you said about sarcoid. The most common cytopenia we see with sarcoidosis is leukopenia. You can see anemia, you can see thrombocytopenia. Usually they tend to be mediated more by hemolytic processes, like an autoimmune process, as opposed to direct infiltration of the marrow, although we should keep our differential broad for sure. Related to the sarcoid, this patient is on methotrexate. Methotrexate is known to be myelosuppressive. Again, typically these weekly doses of methotrexate don't suppress the marrow to this extent. However, if there was some sort of idiosyncratic reaction to being on the methotrexate, which led to this anemia, that certainly could be the case as well. With regards to the thyroid cancer and this exposure to radioactive iodine, radioactive iodine is actually a risk factor for patients developing what's called a therapy-related myeloid neoplasm down the line. So patients that have received prior chemotherapy, radiation therapy, or other radioactive therapy have an increased likelihood and an increased risk of developing a myeloid disease down the line. So that's something we should keep in the back of our minds, not to anchor on it. The other thing I'd be very interested about is if this patient had ever received azathioprine as treatment for sarcoid, because again, that would increase the risk of a therapy-related myeloid neoplasm. I will say it's very interesting that this patient has a chronic anemia, and we almost could have guessed that to some extent when we first heard this story, because presenting with a hemoglobin of 2.5 and actually like walking into the ER and being able to answer questions and be lucid, that in and of itself lets you know that this patient has had some time to accommodate and kind of to being anemic. So then that starts making me wonder, what is leading to this baseline anemia in the first place? This patient walks in with the hemoglobin of 9 several months ago, is now down to 2.5. So we may kind of have two stories that we need to piece together, which is this acute drop, and then why this patient is chronically anemic in the first place. I do, and I love the way you went through what could cause dark urine. You may have said it and I may have missed it, but the one other thing I think about is bilirubin. So urobilinogen. So again, fitting with, could this be dark urine related to a hemolytic process? So I'll stop there. And yeah, we'll see what the next aliquot has.
All right, I'll give you the vital signs first. Temperature in the ED was 97.2. Heart rate was 98. Blood pressure was 106/58. Respiratory rate was 22. SpO2 was 97% on room air. BMI was 28. General exam, she was not in acute distress, just slightly fatigued, looked pale. She's not icteric in her eyes, her head, her neck, no abnormalities, no palpable lymphadenopathies. Cardiovascular exam, regular rate and rhythm, no murmurs. Lung exam, she has clear lungs. The abdomen is soft, non-tender. I will not pretend that I can palpate spleens or livers. Neuro exam is generally non-focal. And she didn't have any purpura or any rash on her skin. And she didn't have any edema. Her pulses were palpable. After the exam, I'm going to briefly give you the CBC, and then you can take it from there. So the initial CBC I got was a hemoglobin of 2.5. The hematocrit was 18.8. Actually, it was 11.1. I'm sorry. The MCV was 119.6. The white blood cell count was 18. The ANC was 12. And the platelet count was 204. I'll stop there.
Fantastic. Sorry, the white count, it's 18,000, you said?
Yes.
Okay, great. All right, Sandra. Some very interesting labs to think about. And also, if there are things from the physical exam, things you have questions about, things you thought you'd see, didn't see, what are your thoughts? I think you're muted. You must share your brilliance out loud with us.
Okay. Sorry. No, I said the CV, it's normal. So I was expecting something would be normal there. Also, abdomen, it's normal as well. So important, I was wondering if she has any rash or purpura. She doesn't have any. Oops. And yes, and basically she's stable. She's stable. What is surprising for me is the MCV, which make me think like a nutritional deficit of vitamin B12 or folic acid. But she's taking methotrexate. That I know it could be related to deficiency. But she's taking folic acids as a medication. But if she's having any problem absorbing the medication as well, it could do nothing and still have the problem. I know that one way to do the difference between the B12 and the folic acid deficiency, you have to look for more lab results. I mean, I'm not sure if it's in reality. It's maybe there's like easier ways or other ways that could be done. But I know during the at least studying on the books to see the methyl uric acid and things like that. So that's my thought for now.
Totally.
And also, let's say with this, if it's a myelosuppression, like if it's affecting the bone marrow, if it was affecting the whole bone marrow, we would expect a pancytopenia, which is not the case. So it makes me think more that it could be like a B12 or folic acid, most likely B12. So that's my thoughts.
Yeah, I love your reasoning. Tell me a little bit more when you hear about a patient who is like B12 deficiency, what type of other symptoms might they have?
So they can have neurologic, which is not the case, neurologic symptoms, but here it doesn't have any.
Yeah.
So usually it's related, that's associated with peripheral neuropathy.
Yeah, I agree. And sometimes when I expect to see if a patient is so vitamin B12 deficient that they have this severe of hematologic abnormalities, I would be definitely looking for those types of symptoms like you're mentioning, like peripheral neuropathy, to see if they have this subacute combined degeneration. I really loved your analysis and thinking about her vitals, and that this patient may be a little bit relatively tachycardic for her age, but really not, fitting the picture for an acute blood loss anemia. And so in terms of shifting my thinking about anemia right now, I'm still thinking is this a hemolytic process, blood cells being destroyed, or is this a production issue? And one of the things, when I think about blood cells being destroyed, I think fairly commonly, I often see a rise, unless it's some type of microangiopathic hemolytic anemia, or we also see a thrombocytopenia. I often expect to see a thrombocytosis for a patient with a healthy marrow and normal liver to compensate, normal liver and spleen to compensate. But this patient does not have a thrombocytopenia. thrombocytosis. And so I'm really wondering, especially in the presence of their elevated, their leukocytosis, if there is something strange going on with the marrow. And I think, you know, when I'm creating my problem list for this patient now, I'm trying to think of like, what is the most specific, like what is the syndrome that I can identify that will give me like the highest diagnostic yield at this point. And you hone right in from the very beginning on like, that is a really elevated MCV. And like MCVs that are greater than 115 is the teaching that I've been taught, like really makes us suspicious for things like outside of like the B12 and folate deficiency area. But I would love to kind of hear our hematology experts comment on that, because this is so outside my comfort zone. And so some other things that pathologies that I think about when I see a macrocytosis or an elevated MCV this high, I do start to wonder about bone marrow pathology. So things like myelodysplastic syndromes. I start to worry about things like leukemia. I think multiple myeloma as well. I've seen present with fairly elevated MCV. I also think about the liver as a cause of an elevated MCV, as well as hypothyroidism. So those are some additional things that I'm going to keep on my radar. I'd want to kind of get some additional studies like coag studies to assess the patient's liver function, get a TSH, really interested to see what their retic count is, what their smear shows. And I mean, this is still elevated MCV, so I totally agree with you. Sending homocysteine and methylmalonic acid, I'm right there with you to evaluate for things like B12 and folate deficiency as well. And also interested to see if there's any other kind of signature of end organ dysfunction, like liver injury or kidney injury, that also could kind of help us hone in on where else this seemingly systemic process is harming the body. But I agree with you. While this patient like is stable from a blood pressure perspective, I'm really worried that there's something like very, very severely wrong with her. And I would be quite early in her clinical course on the phone with Dr. Patel, hopefully holding my hand through this scary diagnostic journey. And I'm interested to hear more thoughts from Fernand.
All right. Let's see if I can help you with this. I'll give you the BMP. Sodium was 137. Potassium is 4.6. Chloride is 101. Bicarb is 21. BUN is 35. Creatinine is 1.65. Glucose is 129. Calcium is 9.5. Phos is 3.7, magnesium 2.6. AST was 43. ALT was 12. Alk Phos was 86. Total bilirubin is 4.8. Direct bilirubin is 1.0. Lipase is 82. Albumin is 3.8. You asked for some anemia labs. I have an LDH of 1200. I'm not sure where it's coming from. The reticulocytes, which is something you've been yearning for. Let me just find them. So the reticulocytes were 200, absolute number. And peripheral smear did not show any schistocytes. Did not actually showed some spherocytes, no schistocytes, and it showed polychromasia. And there were some cells that are really close to each other. We didn't really know if it was an artifact. There was a CAT scan, obviously done in the ED for no specific reasons, and it showed bulky mediastinal and hilar lymphadenopathies with coarse calcifications and multiple parenchymal nodules in the lungs, consistent with interstitial lung disease. And overall, this was suspicious for pulmonary sarcoidosis, and there was a splenomegaly. So I'll stop there.
All right, Mario, what are you thinking?
This is a hard aliquot, to be honest. The first thing that came to mind is something I had been thinking previously, that this patient had an ongoing anemia, right? So maybe we're dealing with two processes, one chronic and one acute. And one thing that comes to mind is, could this be could this patient be complicated by pure red cell aplasia from, for example, parvovirus B19? That's something that I was thinking. In terms of the macrocytic isolated anemia, this could be, first of all, is that, are those retics high? I'm not sure. I think that's an important period point, but I'm not sure if that's normal or low or high, because reticulocytosis in itself can cause a microcytosis, because those cells are typically bigger than normal red blood cells. And if they were low, we could suspect a hypoproduction type of process. And in terms of the peripheral blood smear, I think then the absence of schistocytes is reassuring for a TMA, but the fact that we can see some spherocytes, I know we can see that in autoimmune hemolytic anemia, also hereditary spherocytosis, which could explain the 4.8 of total bilirubin, because normally the range for total bilirubin in hemolytic process is usually around 4 or 5. So that could, maybe we could be dealing with something like that. I'm not sure if we got an haptoglobin. I would be looking for that too, if we were suspecting a hemolytic process. And in terms of the bulky mediastinal and hilar lymphadenopathy, something that came first to mind is, I recently read that, for example, thymoma can cause a pure red cell aplasia, but that of course is not in play here, because this is probably from the sarcoidosis. So what I'm thinking right now, is this related to the sarcoidosis? For example, if this, I'm not sure how it could be related. Is this related to maybe the methotrexate, like you mentioned? Maybe that could, because that can cause also a macrocytic anemia, or is this, or are we dealing with two processes, one chronic and one acute?
Mario, that was excellent. I really don't have too much to add, but I'll try. So here we have an isolated anemia, an isolated macrocytic anemia. I love the point that you made about how reticulocytes are going to increase your MCV, and spherocytes will do the same. So now we're starting to build a little bit of a story of why is it that this person's macrocytic, you know? Could it be a combination of methotrexate and an autoimmune hemolytic anemia with a brisk reticulocyte response? Potentially, that could potentially explain this degree of macrocytosis. Moving to the chemistries, we have laboratory evidence of a hemolytic anemia. We have an indirect hyperbilirubinemia. We have an elevated LDH, extraordinarily elevated LDH. And we, so from the chem, those are the things that I would pull out. With the reticulocyte count, I'm typically used to having the retic count reported as a percentage, but just even eyeballing it, 200 is probably in the normal-ish range. So it's probably an inappropriate compensation. So this really, I think, feeds into that story of chronic process with an acute insult. And I start thinking, maybe the story here is a patient with anemia of inflammation, potentially from this underlying sarcoid and rheumatoid arthritis, who's now had an acute insult of a hemolytic anemia that's led to this hemoglobin of 2.5. I think the things that'll help us tease that out a little further would be checking a haptoglobin, like you said. I think getting a Coombs and an indirect Coombs test to look for the presence of IgG and IgM antibodies that could be potentially driving an autoimmune hemolytic process. But honestly, my threshold to do a bone marrow biopsy as part of this patient's workup would be quite low. This degree of anemia and this degree of macrocytosis in the context of prior kind of exposures that could put this patient at risk of developing a therapy-related myeloid neoplasm down the road. If there was any lack of clarity after getting a Coombs test and after confirming a potential diagnosis of autoimmune hemolytic anemia, I would go ahead and get a bone marrow biopsy as well to rule out some primary marrow process as well. Again, I think there is both a chronic and acute process going on here. So ultimately, we may end up arriving at two separate diagnoses.
I have a quick question. I think someone mentioned early, I think it was Anna, that nitrofurantoin could cause hemolytic anemia. Is that through like causing an autoimmune hemolytic anemia, or when she mentioned that, what came to mind is maybe that's causing I don't know, elevated oxygen reactive species, and that could maybe she had an underlying G6PD deficiency, and that could be, I don't know what the mechanism of that.
That's a great question, Maria, and I don't know the mechanism off the top of my head, but I believe it's through reactive oxygen species as well. The big issue here in terms of whether or not we'd want to work up this patient for G6PD deficiency is when patients are having active hemolysis with G6PD deficiency, their G6PD levels are actually falsely normal because the reticulocytes, the healthy reticulocytes that are being churned out will have normal levels of G6PD. So even if that's something that's on our working differential, we would stabilize, see these hemolysis parameters improve, and then we would think about sending it down the road.
Right, so I got lost because I got paged. So I see that you were talking about hemolysis. Is this your working diagnosis?
Yeah, we were talking about maybe, some sort of chronic process contributing to this patient's anemia, maybe an anemia of inflammation or something like that, with hemolysis being the acute driver of this presentation with the hemoglobin of 2.5.
Okay. All right, I'll give you some more anemia-related tests. So ferritin was 893. Folate level was 8.4. Vitamin B12 was 913. Talked about the peripheral smear. There was a Coombs test that was ordered. The polyspecific Coombs test was positive. When we tried to kind of know more about what was positive in the Coombs, it appeared that there is IgG positivity, but there's also a component of IgM. And I'll stop there.
Is there any other data before the final diagnosis is revealed for non, just for the sake of time?
No, that's actually, I mean, it's just in the summary, basically.
Okay. Cool. Okay. Well, maybe we can, Sandra, you and I can start, and then if Mario has anything to add, and Anand as well. What are your thoughts, Sandra?
So I'm not sure about the levels of the. It seems that just the ferritin, it's abnormal.
It's elevated. And when you think of elevated ferritin, what do you think of?
I don't know how to explain. So I think for that part, I would let you explain that, like share your thought.
Yeah, absolutely. When I think of like an elevated ferritin, I think of like just general like inflammation happening in the body. And I think that really fits the narrative that's been nicely painted for us. Of there being something chronic in the background, we see that this patient has, diffuse lymphadenopathy. And I think we very much have a signal for something chronic in the background causing chronic inflammation with like an acute process. What about the Coombs test? What have you heard about the Coombs test before? What typically is the test what is it showing us?
Oh, usually we do the Coombs test to see agglutination. Mostly it's commonly done on pregnant and their child to see any incompatibility on the blood groups. So if it's positive, it means that it has a production of antibodies against, and so there is a immune reaction. In other words, in short, there is an immune reaction going on here. She has a history of she had, I think, rheumatology arthritis, I believe, yeah, and sarcoidosis, which as well, it's a genetic predisposition to have an immune reaction. So all of that could be related, but it's definitely related to this. I'm wondering that definitely we're talking about a chronic disease with an acute presentation of something else. And I'm wondering what the COVID vaccine would play in this case. Not sure yet, but yeah.
So interesting. I had totally forgotten about the COVID vaccine. Thank you for bringing us back to that very interesting and big immune load that this patient got just 1 week prior. And I don't know how that'll fit into the picture either. The interesting thing that I'm not used to seeing on this Coombs test is the presence of both IgG and IgM positivity, suggesting like a mixed warm and cold hemolytic picture. Normally, I expect to see either IgG positivity or IgM positivity. More, I think, warm autoimmune hemolytic anemias are more common. And so I don't totally know how to interpret this kind of mixed picture that we're seeing, but I wonder if there's going to be some type of connection to an underlying lymphoproliferative process with this patient's kind of diffuse lymphadenopathy, or if there's perhaps a hiding solid organ malignancy in one of these nodules that we're seeing, or some type of other undiagnosed malignancy that are, commonly seen with hemolytic anemias. But, this COVID vaccine, could that be contributing? Could there be, some type of subclinical and infectious process with her recent fevers? Or could she be having like a flare of one of her underlying autoimmune diseases like sarcoid or RA? We're not really getting a review of systems that support that, but of course, anybody with an underlying autoimmune disease or at risk for other autoimmune diseases, so just you have something undiagnosed that we just don't know about yet. I think I'd be interested. I mean, I'm really curious to hear what the final diagnosis is. I wonder if that will be like in the form of a lymph node biopsy.
Yeah.
Yeah.
No, I just wanted to say that despite that, patients that having an underlying immune disease, they are predisposed to have other immune diseases. And being a female as well, there are many more predisposition for, and I know that lupus can have a mixed, the IgG and IgM, but depending on the case's presentation. Yeah, so I stopped there, and for the sake of time, we wanted to move on.
That was awesome. I didn't know that. Thank you for teaching that. Are there any other final thoughts, Mario or Anand, before we get the final diagnosis?
Mario, do you have any thoughts?
Yes, just to add to what Sandra brilliantly said, I think apart from malignant processes that can cause a secondary autoimmune hemolytic anemia, and besides lupus, I think rheumatoid arthritis is a cause of like a secondary autoimmune hemolytic anemia. I don't know what to do with that mixed pattern. I think I think yeah, I don't know what it would, I don't know how it would work that up. Maybe work both differentials. And something that came to mind is rheumatoid arthritis plus splenomegaly and plus a cytopenia. I remember associating that with Felty syndrome, but I think that's typically with neutropenia and not anemia. And I think the positive Coombs test here really really solidifies our working diagnosis of an autoimmune hemolytic anemia. How to differentiate idiopathic from a secondary, I really don't know.
Yeah, the only thing I'll add here is, it's certainly important. I think we're at a point where we can say this patient has a autoimmune hemolytic anemia. Warm autoimmune hemolytic anemias are far more likely to be driven by an underlying autoimmune disease. Cold agglutinin disease or cold autoimmune hemolytic anemias are far more likely to be driven by a lymphoproliferative process. So I think, even if we come to a final diagnosis, given the fact that this patient has IgM positivity along with IgG, I would still want to think about either doing some sort of tissue sampling, whether it's, given the fact that this patient is anemic to this extent, I would, I think it'd be reasonable to start with the bone marrow and then go for a lymph node if unrevealing. Other things that should be done are serum protein electrophoresis, immunofixation, sending off things like infectious causes like EBV, CMV, mycoplasma. The journey kind of begins at autoimmune hemolytic anemia when you get to that diagnosis. It certainly doesn't end there most times.
All right. So as you clearly identified, there seems to be a mixed type autoimmune hemolytic anemia, which is pretty rare. We tried to look for infectious causes. We tried to look for lymphoproliferative causes. Mycoplasma IgM was negative. EBV PCR was negative. These are the two main infections that drive autoimmune hemolytic anemia. And bone marrow biopsy didn't show any lymphoproliferative disorder. There was adequate erythropoiesis, basically. And the whole process in the chest seemed like it's chronic and related to sarcoidosis that's kind of dormant. And the SPEP was all polyclonal. So, I mean, from what we have right now, it seems that her mixed autoimmune hemolytic anemia is driven by the autoimmunity that she has, basically. And we treated the cold, the warm component with steroids, prednisone, and the cold component with rewarming. We get it. The cold component doesn't respond to steroids. It's very hard to respond to steroids. So we had a plasmapheresis session to try to kind of remove as much IgM as possible to kind of get this under control. And then we started infusing rituximab, which is maybe the first line treatment to treat the cold agglutination disease. So why do we have a really high MCV in this case? It's in part due to the reticulocytes, but also due to agglutination. And you can also see in her RBC, hemoglobin, hematocrit continuum, where you generally jump by multiplying by 3. So red blood cells times 3, you get your hemoglobin, times 3, you get your hematocrit. You will have a discrepancy when jumping from a hemoglobin to the hematocrit. Sometimes it's like 2 or 1.7. And this is where you know that you have agglutination. And after plasmapheresis, this number improved more towards 3. So this is what I have for you, and this is a pretty rare entity, but it covers both ends of the spectrum, and it's still a work in process in this case.
Fernand, such an amazing case. As always, you always bring the heat when it comes to the cases you present. Mario and Sandra, I'd love to hear your reflections. Just because we're running over on time, I'll quickly just say that you both were absolutely spot on with your reasoning. So incredible in terms of taking each aliquot and kind of layering it on top of the information we had. And yeah, I mean, I could go on for many minutes about how great both of you did, but truly excellent clinical reasoning on display by both of you.
Thank you so much. Oh, very interesting case. And it was a really good, refreshing and reminder for hematologic disorders and hemolytic anemia. And I learned a lot. Was pretty interesting. Like, I think I will be more attentive now, especially with the difference, discrepancy between the hemoglobin and the hematocrit and other labs results that we discussed. And thank you so much for having me. I'm sorry, I just have a question. What are your thoughts on the COVID vaccine in this case? And what would be like a trigger for this hemolytic anemia? Your thoughts on that?
I'm inclined to say that COVID vaccines are red herring, but what are your thoughts?
Yeah, I would agree with that. I think, this woman has a documented history of autoimmune disease kind of beneath the surface. And I think whether it was a UTI or whether it was the nitrofurantoin that may have been the trigger, either of those, I think I'd point to prior to the COVID vaccine. But I think part of that is because I always want to believe that our vaccines are incredibly and exceptionally safe, which they are. This is something that even if it was related to the COVID vaccine, clearly would be the rarest of rare complications, I would say. So.
Oh, sorry. And just another question. I remember Fernand said that to be attentive to maybe she was misdiagnosed with UTI before the week before. So I wanted to hear his thoughts on that. Why he said that he was misdiagnosed with UTI? What was the real diagnosis, or what, I think he's not here. That's fine, no worries.
I think yeah. Oh, Anna, please go ahead.
I was going to say, I bet you, if you reach out to him on Twitter, he'll be more than happy to fill you in. But Anand, what were you going to say?
I was just going to say, I think it's a diagnosis that we make frequently because it's easy with sending a UTI and seeing some findings like leukocytes or white blood cells. But clinically, very frequently, patients don't truly have a UTI even when we give them that diagnosis. So that may have been what Fernand was getting at. Let's turn it over to Gurleen to run us through these teaching points, because we've kept our audience base far past the hour. So let's do that and get people home.
Yeah, so this is a really interesting case. I know we're running over time, so I'll try to keep it brief. So the first thing when we approached this patient, a 70-year-old female with a hemoglobin of 2.5, was to really assess if she's stable, hemodynamically stable, and what are the red flags when we're examining her. This is a case where it's not just the diagnosis and the clinical reasoning, but we have to make sure that our patient in front of us is someone who's stable. The other aspect was that someone with a hemoglobin this low coming in like this, it couldn't be something that happened just that quickly. There's probably a component of acute on chronic anemia. So the other aspects that we focused in on in this case was who was this patient, what were her risk factors. So the nitrofurantoin, the medication use, could that be contributing to an autoimmune hemolytic anemia, or the methotrexate leading to suppression? The other aspect was the history of the sarcoidosis and the autoimmune diseases, thinking that sarcoid can cause autoimmune effects, but also infiltration of the bone marrow. The other aspects that we talked about were radiation therapy. People who have radiation therapy might have an increased risk of developing myeloid disease and have other risk factors. The other aspect of the case when we're trying to approach it was what other clues are there? So the weight loss, is there a chronic inflammatory process that's going on that's contributing to this acute on chronic nature of the disease, as well as the dark urine. Is that because of hemoglobin, myoglobin, or high bilirubin from hemolytic anemia? Those are three important causes to keep in mind. The main thing that we were thinking about our schema was for anemia. So when we're thinking about it, where are we losing any blood? So always think about the base rate of disease. So like the GI tract, the GU tract, gynecologic reasons, things where you can lose blood. The other approach to anemia is to think if it's an issue with proliferation, with production. So is it because of the bone marrow, or is it due to destruction like hemolysis? Hemolysis being different diagnoses causing hemolysis. And then the next aspect was the pivot point of the case was really the macrocytic anemia and other labs that showed hemolytic anemia. So when we're thinking about macrocytic anemia, a way to approach is it megaloblastic or non-megaloblastic? So megaloblastic is when you have decreased DNA synthesis, and that's causing your red blood cells to not be able to mature, and they're larger in size. So that could be due to nutritional deficiencies like B12 or folate. The other aspect is non-megaloblastic anemia, which could be caused due to high reticulocyte count because reticulocytes are larger, or as well as because of hypothyroidism, liver disease, and myeloproliferative myelodysplastic syndrome. The other things that the labs were really important in this case was to look for if there's schistocytes for hemolytic anemia, but also to remember that spherocytes and reticulocytes can increase your MCV, and that could be why this patient presented with a high MCV. The other aspects where we kind of reframed our hypothesis when we got the labs and imaging was that there's this splenomegaly, there's this lymphadenopathy. So there's definitely a chronic component of the disease going on, but then there's this acute decrease in hemoglobin and other aspect. So that reframed our initial hypothesis that this is an acute on chronic process. And then really the hemolytic anemia, when we think about that, there's different ways to approach it. One approach is to think if it's something in the environment causing it, like MAHA or trauma, if it's something in the membrane. And something in the membrane could be intrinsic or extrinsic being autoimmune causes. And then the internal causes of hemolytic anemia would be like hemoglobinopathies, G6PD deficiency, as well as other infections being an extrinsic cause. And then the last aspect was the autoimmune hemolytic anemia. And when we're thinking about that, there's warm and cold agglutins. And in this case, it was more complicated because there was a component of both. But really a great pearl from Anand was that warm autoimmune hemolytic anemia is more likely to be due to autoimmune causes, while cold is more likely to be due to lymphoproliferative disorders. And when we're approaching autoimmune hemolytic anemia with the Coombs test, other things to work up would include infections like EBV, CMV, as well as mycoplasma and other aspects. So yeah, thank you everyone for joining. This is a really great case.
That was awesome, Gurleen. What a pleasure to learn from you. Those teaching points, so organized, so high yield. I learned new things. Thank you all so much for joining us. We're excited to see you all at other VMRs later this week, and we hope everyone has a nice rest of your evening or day, depending on where you are in the world. Take care.